Good morning, everybody. I'm Matt Oliver. I am very excited to be here this morning and to also to be joining Dr. DePasquale in the group. It's an exciting time for my wife and I to be moving back to the Tennessee area. As Dr. D said, him and I, we did a fellowship at the same area or the same program. So any of the residents that are tuning in, our program coordinator sent me home with a few pictures of Dr. DePasquale that might come in handy to you at certain times. So don't hesitate to reach out to me if I can be of any assistance for that. This morning, I'm going to be given an update on gynecologic cancer care entitled Not Your Father's Oldsmobile. So I remember being a med student and a resident, and when you talk about GYN cancers, the answer was always carbotaxol. Carbotaxol for everything. It didn't matter what cancer sites, that was the upfront treatment and sometimes used in recurrence also. And we've made some huge advances, specifically just in the last kind of 5 to 10 years that are really transforming our treatment options available for patients that are giving better outcomes and also associated with less toxicities. So when we look at survival curves, they're often there in our trials. We see that with our standard of care, which is typically that carbotaxol, we do a pretty good job of shifting that curve to the right. And so increasing the time of progression-free survival or of dying from the disease. But essentially what that's doing for us is kind of kicking the can down the road. And so the question is, instead of shifting that curve to the right, is there a way for us to actually elevate those survival curves? And so instead of just providing more time, can we actually increase the survival rates to have a curve that looks more like this? So we'll go through the three main GYN cancers. We'll start off with ovarian cancer first. Just a brief overview, a little over 20,000 new cases of ovarian cancer in the US every year. Approximately 13 to 14,000 women die of the disease every year. When we speak of ovarian cancer, it's a big basket term, and it's formed of multiple different cell types. But 90% of our cases are epithelial ovarian cancer, and the majority of these are high-grade serous tumors. Thankfully, our incidence of ovarian cancer has actually decreased over the last decade and a half. Rates are declining by about 1.6% per year. And our mortality trends have also decreased by about 2.3% per year. And we'll get into some of the specifics about why that is. The kind of big trend in ovarian cancer now is the use of PARP inhibitors. So we won't get into the nitty gritty, but I think it is a good idea to have a brief overview of what PARP inhibitors work and why specifically do they seem to work really well in BRCA patients. So in the top right corner, you can see that DNA single-strand breaks occur continuously during the cellular processes. And PARP detects and repairs them. And so during the replication process, if unrepaired single-strand breaks, they're converted into double-strand breaks. And what PARP inhibitors do is they inhibit PARP, so therefore preventing that repair of single-strand breaks, which increases the number of double-strand breaks that we have. In a normal cell, there are multiple different ways for DNA to repair itself. And so they still have homologous recombination to repair the cell. And so even in the presence of a PARP inhibitor, the cell can still repair itself. However, in BRCA mutated patients or BRCA-like patients, they don't have the ability for homologous recombination. And therefore, since we're already blocking the single-strand repairs with PARP inhibitors, they inherently don't have the double-stranded break repairs. And that ultimately leads to cell death. The buzzword that you hear for that is synthetic lethality. The history of PARP inhibitors in ovarian cancer actually doesn't extend too far back. 2014 was the first approval for PARPs in ovarian cancer. And it initially started in the recurrent setting, actually the multiple recurrent setting, and used as a treatment with olaparib in 2014. And then you can see as we progress, there was an increase in the number of PARP inhibitors that were approved in the recurrent setting. It wasn't until December of 2018 when olaparib was approved for the first-line maintenance, specifically in BRCA patients. And then since that time, we've also seen approval for niraparib in the first-line maintenance also. So when we talk about transitioning out of just the carbotaxol and just the treatment phase, we're also entering into patients being on a maintenance phase to try and improve the progression-free and overall survival. In looking at there's 3 different PARP inhibitors that are approved, olaparib, rucaparib, and niraparib, all approved for ovarian cancer. They're all pill forms, which is very nice to prevent patients from coming into the infusion center continuously. This was also very helpful during COVID to try and decrease the number of appointments that patients needed. The starting doses are a little different between each, and the side effects are actually quite tolerable and very different from chemotherapy. The main side effects that we see with these, we keep a good close eye on the blood counts. Sometimes they can get some anemia or thrombocytopenia. And there tends to be some nausea when they first start taking the medications, but that actually improves after the first month or so of being on it. And so it's very rare for patients to have to discontinue these treatments altogether because of side effects. There were 4 big clinical trials that came out looking at PARP inhibitors over the last 2 to 3 years. We'll briefly run through these because it's important in how they were approved by the FDA and how we use them. So the first trial, SOLO-1, was looking specifically at patients with a BRCA mutation, and looked at those patients that respond to their upfront chemotherapy, and they are randomized into 1 of 2 groups. So one group got olaparib 300 milligrams twice a day until they progressed. The other group got a placebo. And the Kaplan-Meier curves that we see for these are curves that have not ever been seen before in ovarian cancer. And so the red is the placebo group. So they just got the chemotherapy and then continued on placebo maintenance afterwards. And the blue received the standard chemotherapy and then received olaparib afterwards. And you can see that even up to close to 5 years afterwards, the median progression-free survival hadn't even been reached yet in the olaparib group. And in a lot of these trials, we focus on the hazard ratio, and a hazard ratio of 0.3 means that the group that received the olaparib was 70% less likely to have a disease progression or death compared to the placebo group. So this has been groundbreaking in ovarian cancer care for our BRCA patients, and it's now standard of care for all of our ovarian cancer patients to receive genetic testing and those with BRCA mutations to receive PARP inhibitors as maintenance. So in December of 2018, the FDA approved olaparib for the maintenance treatment of adult patients with BRCA mutations or suspected BRCA mutations. The second trial is a PRIMA trial, and this was looking at a similar disease in ovarian cancer with the serous and endometrioid high grade, but they were not BRCA positive. So this is kind of all comers with ovarian cancer. And they also were randomized into 2 groups, niraparib every day for 36 months or a placebo maintenance. And we can see here the curves, while not quite as good as what we saw with olaparib and BRCA patients, which that's what we would expect to see. Because if you remember back at the beginning with the synthetic lethality associated with BRCA patients, they tend to respond much better than our non-BRCA patients. However, the hazard ratio was still very significant, and that those that received niraparib had a 40% less likely chance of disease progression or death. And so in April of 2020, the FDA approved niraparib for the first-line maintenance of advanced ovarian cancer in all comers. So it doesn't matter if you had a BRCA mutation or not. Everyone is eligible to receive niraparib as maintenance. The third trial is the PAOLA-1 trial, and this looked at stage 3 and 4 ovarian cancer patients. They could have either received neoadjuvant chemotherapy or primary debulking surgery. The main difference between this trial and the other ones are that they got olaparib for 24 months, and then they also received bevacizumab, both in their upfront treatment and as maintenance. And then in the placebo group, they did not receive olaparib, but they did continue on the bevacizumab for maintenance. And we can see here that, again, a significant improvement in the survival curves, a 40% less chance of disease progression or death in those that received olaparib plus bevacizumab. So all comers were allowed into this trial. The authors kind of broke down the groups, whether they had a BRCA mutation, if they were HRD positive but did not have a BRCA mutation, and those that were BRCA negative and did not they were homologous or combination proficient. And we can see that the groups that included the BRCA patients had a much better hazard ratio, but even the group that was not BRCA positive but was HRD positive had a pretty impressive hazard ratio, whereas those that were HRD negative and BRCA negative, not quite as much. And so that led the FDA to approve olaparib plus bevacizumab as maintenance treatment for ovarian cancer in patients that are either BRCA positive or HRD positive and had received bevacizumab as part of their upfront treatment. The fourth trial is the VELIA trial. Again, very similar patient cohort, stage 3 and 4, high-grade serous ovarian cancer. This had 3 different arms to it compared to the other 2. So patients received either chemotherapy and then followed by placebo as maintenance, or chemotherapy plus veliparib, which is a PARP inhibitor, during their upfront treatment. And then once they finished that, they had placebo and maintenance, versus receiving chemotherapy plus a PARP inhibitor for their treatment and then the PARP inhibitor as their maintenance. And what they saw here is that, again, with the other ones, patients that were either BRCA positive, which is the top gray line here, or HRD positive, which is the orange line there in the middle, did much better than those that were BRCA negative and HRD negative. So there is no FDA approval yet for veliparib. We expect that to be forthcoming. The difference in this trial is that the PARP inhibitor was given in conjunction with the chemotherapy. And one of the important parts of that is we saw that this was tolerable. So the side effects between PARP inhibitors and chemotherapy are different, but they can be given together, and patients seem to tolerate that well. So we're encouraged about possibly adding PARP inhibitors even to the chemotherapy regimen. Moving on from ovarian cancer to endometrial cancer, about 66,000 new cases of endometrial cancer in the US per year, close to 13,000 deaths. And unlike ovarian cancer, where we've seen a decrease in the incidence and a decrease in mortality trends, we've actually seen an increase in both in endometrial cancer. There are a few different theories behind why that is. Obesity tends to be a significant driving force for that. So as we see obesity numbers increase, we're also seeing increased incidence and mortality with endometrial cancer. And the updates in endometrial cancer are really focusing on the mismatch repair proteins. So you might hear a lot about microsatellite instability or mismatch repair. Just a brief overview of that. There's 4 proteins that are associated with mismatch repair, which is one of the ways that cells use to repair single-stranded DNA breaks. And so essentially 2 of the proteins join together to form a heterodimer, which identifies the mutation that's there. They then recruit the other 2 additional proteins to come in and kind of remove that area of the mutation. And then DNA polymerase comes in and repairs that DNA. And then you have a completely repaired DNA in a fully functioning cell. So this is how the system is normally supposed to work. In endometrial cancer, we do see that there oftentimes are mutations or hypermethylation within those mismatch repair proteins. And so for all of our endometrial cancer specimens, we test all of them for to see if these intact or see if these proteins are intact or not. And our pathologists do a wonderful job of triaging this for us and doing immunohistochemistry stains to check to see if the proteins are intact or not. This provides both kind of diagnostic and therapeutic option information for us, because if we do know that these proteins are not functioning, that patient might be eligible for genetic testing to check for Lynch syndrome. And it also alters the therapeutic options for what we have available to them. And we'll get into both of those in the next few slides. So in looking at Lynch syndrome, historically, it has been just criteria based on family history that indicated whether a patient should be referred for genetic testing or not. And thankfully, due to our universal screening on our endometrial cancer patients, we're picking up more and more patients that should receive Lynch syndrome testing. And the benefit of that to the patients is, as you can see here, women with Lynch syndrome are at a significantly increased risk for cancers in multiple different sites. And so once we identify that they do have Lynch syndrome, they can either go prophylactic surgeries to decrease that chance of developing a cancer in the future, or increase surveillance and screening if surgery isn't an option. In looking at the therapeutic potential of identifying patients that have mismatch repair deficiencies, one of the things we see is that there's a very robust immune response in patients that do have the mismatch repair deficiency. And the take-home point from this slide is just all of this brown area here. These are T cells. So this is your body's natural immune defense. You can see it kind of flooding the tumor area in a patient that does not have intact mismatch repair, versus someone who does have intact repair. There's not as big of an immune response. And so that has really changed how we can treat patients that do have either Lynch syndrome or a Lynch-like syndrome. So when we look at, how do we treat cancer? There's basically kind of 3 pillars that we follow. Surgery, we can cut it out. Chemotherapy, we can poison it, or radiation, and burn it. And so these have been kind of the mainstays of cancer care for the last several decades. But the question is could there be a 4th pillar? And that 4th pillar being immunotherapy. And that kind of rolls off of the mismatch repair and the increased immune response that we see in those particular tumors. So a brief overview of just the T cell and the immune synapse. T cell has to be activated by 2 different receptors. You have the T cell receptor and then the CD28 receptor. And the way that gets activated is an antigen-presenting cell that's circulating throughout the body, identifies specific antigens and actually brings them back to the T cell. So the antigen-presenting cell has the activator for the T cell receptor and then brings in a specific antigen to interact with CD28. You can think of it as kind of a car. So it has to have the dual activation in order for T cells to be activated. And so the T cell receptor is like the ignition key, and the CD28 is like pushing the gas pedal. Without both of those things, the car is not going to move. And so once those two things are activated, the T cell then begins to rapidly divide and send a response to the antigens that the antigen presenting cell delivered to the T cell. So the way that works is you have an activated T cell now because it's the ignition switch was turned on and the gas pedal's been pushed. So T cells then release multiple interleukins and interferons that eventually go back to the invader, whether it be an infection or malignancy, and eradicate those cells. The issue is if our immune system is an incredibly powerful tool for our body. So if this system were not kept in check, it would attack every organ within our body. And so those same interleukins and interferons that go and kind of target the infection or the tumor, they also kind of help put the brakes on the immune system by leading to expression of CTLA4 and PD1. And so that's how the T cell is kept in check. Understanding of that mechanism has led to, when we talk about immunotherapy, there are several different types of immunotherapy. The one that we'll focus on today are called immune checkpoint inhibitors. And so that focuses on that brake system of the immune cell. And so immunotherapy, essentially, if you're blocking those receptors, you're releasing the brake on the immune system. And this trial was a basket trial, meaning that it kept tumors from multiple different sites. So it had colon cancer and endometrial cancer and a few other cancer sites in there as well. And what we saw was that in those patients that, so mismatch repair proficient, so they were able to repair their DNA, they didn't have any mismatch issues. They didn't really respond as well to the immunotherapy versus those that did have mismatch repair deficiency that saw a significant decrease in their tumor marker levels. And then here in figure B, this is looking at radiographic response, so actually measuring the size of the tumor lesion. You want to be on the kind of bottom part of this graph, and anything below this dotted line is a greater than 30% decrease in tumor volume. And so we can see that those with mismatch repair deficient colorectal cancer and endometrial cancer had a significant portion when treated with pembrolizumab. And so in May of 2017, FDA granted accelerated approval to pembrolizumab for the first tissue or site agnostic indication. So it doesn't matter where the tumor originated from, if there is a mismatch repair deficiency, they are eligible for pembrolizumab. The second trial was looking at, can we provide these medications to patients that maybe don't have the mismatch repair deficiency? Is there something else that we can give them that helps them respond to the immune checkpoint inhibitors? And they received two different medications with this, lenvatinib and pembrolizumab. Lenvatinib is a VEGF inhibitor, so it helps stabilize the blood vessels. And the thought behind this is that if you are able to stabilize the blood vessels, more of those T cells can actually get within the tumor. And so what they saw was a significant improvement in progression-free survival in those patients, even if they didn't have a mismatch repair deficiency, if they received both the lenvatinib and the pembrolizumab. And so this led to approval of pembrolizumab plus lenvatinib for treatment of patients with advanced endometrial cancer that is not microsatellite unstable or mismatch repair deficient after they have already had their upfront chemotherapy. And this trial looks specifically at serous endometrial cancer. So this tends to be one of our more aggressive forms of endometrial cancer. This was looking at adding Herceptin to the carbotaxol, and Herceptin specifically targets HER2. This again added that trastuzumab or Herceptin to upfront carbo and Taxol. And what we saw again was a significant improvement in progression-free survival and in all stages, but specifically in those patients that had advanced stage, so stage 3 or 4 serous endometrial cancer, saw over or close to a 10-month improvement in their progression-free survival. And so that led to the approval for using Herceptin in our advanced stage serous endometrial cancers. Now, moving onwards towards cervical cancer, there are approximately 14 to 15,000 new cases of cervical cancer in the U.S., a little over 4,000 deaths associated with it. And the rates have stayed relatively stable over the last decade. And our mortality rates have decreased slightly, but not too significantly. One of the things that we're trying to do with cervical cancer is one of those that the majority of cases can be preventable with HPV vaccine. And so hopefully as we see those numbers increase, we will see a significant decrease in the incidence. Immunotherapy, just like used in endometrial cancer, is also used in cervical cancer. And this keynote study specifically looked at the PD-L1 receptor, which is that receptor that's expressed that puts the brakes on the immune system. So if patients have if they are PD-L1 positive, so if they do express that receptor, you can see that when treated with the pembrolizumab, they have a significant decrease in their tumor volume. Again, you want to be below this 30% curve. The big kind of wrecking ball that came in to cervical cancer treatments over the last couple of years has been how do we treat this surgically? With early stage cervical cancer, surgery has been the mainstay of treatment, and oftentimes patients don't need adjuvant therapy afterwards. We've done previous studies looking at minimally invasive surgery and other cancer sites, specifically in endometrial cancer. And several non-inferior studies have shown that minimally invasive surgery was no less effective than open laparotomy surgeries for endometrial cancer. And so Dr. Ramirez at MD Anderson helped develop a phase 3 multi-center study. It was actually an international study looking at minimally invasive versus abdominal radical hysterectomy for cervical cancer. So we had a non-inferior study showing that it wasn't any different in endometrial cancer, but we did not have any data showing that in cervical cancer. I would say the majority of the GYN oncology community believed that this would be just like endometrial cancer and show that there is no difference. However, kind of shockwaves went out when they presented this at SGO back in 2018. And this study was actually stopped prematurely because the monitoring committee noted that there were significantly worse outcomes in the minimally invasive group compared to the open group. And that's what both of these figures are showing here. So to the left shows that open surgery is better. And you can see that both in the intention to treat population and in the per protocol population, this is far to the left of the non-inferior boundary. And then looking at the proportion of patients that were disease-free, you can see that the curve in the minimally invasive surgery is below that of the open surgery. And the big difference for this is that, oftentimes cervical cancer patients are significantly younger, and we expect to completely cure them with surgery alone. Whereas recurrent cervical cancer, we consider in most cases to not be a curable disease. And so it's pretty significant if we are not providing the right surgery up front. This then prompted some other investigators to look back retrospectively at SEER data to see, all right, this randomized trial showed it. If we look back at this data, what do we notice in survival? And they put together this really interesting figure looking at the 4-year relative survival percentage, and then overlapping that with the rate of minimally invasive radical hysterectomy. And so you can see that as minimally invasive radical hysterectomy increased in the percentage of those that were undergoing that, it really picked up back in 2006. At that inflection point, that's where we started seeing a decrease in survival. And so those two curves overlapping, or that inflection point, really kind of helped to reinforce what we saw in that randomized trial. And so now for, I would say, the majority of patients that are requiring a radical hysterectomy, unless there are very specific circumstances, we have switched back to from a minimally invasive to an open approach. There are other studies that are ongoing now to try and either kind of validate or refute those previous studies. So that's an ongoing process now. But this has really changed how we take care of cervical cancer patients. And so, those studies that I presented are, international studies, multi-center studies. And so the question is, what is the program in women's oncology here in Chattanooga doing to help advance the field? And the answer is we're participating in these trials. And we are very thankful to be able to offer these trials to the women in the area. And our goal is to only increase the number of clinical trials that are available. And so when you look at the different disease sites, so specifically in upfront ovary, we have 3 different trials that are incorporating immunotherapy into the treatment. So again, helping to advance the either combinations or the types of treatment that these patients can receive. In looking at uterine cancer, we also have 2 available studies open, looking at durvalumab, which is a type of immune checkpoint inhibitor, and then also pembrolizumab, which functions in a similar way. And then also with cervical cancer, again, 2 different studies that are looking at immunotherapy. And so in summary, I think one of the take-home points should be, what should you tell your patients? I think it's important to let patients know that there is hope. There is hope both with our current treatments that we have available, and also hope that new treatments are becoming available with those clinical trials that we're currently doing. We are always available to either talk over the phone or see a patient in consultation. So if you have any questions about what to kind of say to patients before they come see us, we'd be more than happy to go over that. And then obviously, more than happy to help see and take care of those patients. All right, thank you.
If anybody has any questions, they can type them in the chat box, please. Thank you, Dr. Oliver.
Should I just leave this pulled up? Yeah, okay.
We want to thank Dr. Oliver for his time. If everybody would please type their name in the chat box for each session that you attend. We are taking attendance. We will take a break until 9:15 until our next speaker. Thank you.